Next is urinary calculi screening. Renal calculi or kidney stones are formed by the crystallization of calcium oxalate, which is most common, magnesium ammonium phosphate, calcium phosphate, uric acid, and cysteine. Formation of stones may be due to reduced urine flow and excessive amounts of the above-mentioned insoluble substances. The presence of stones is confirmed by diagnostic visualization, or passing of the stones in the urine. The chemical nature of the stones is confirmed qualitatively. A formation of calculi can result from reduced urinary volume, increased excretion of mineral salts, urinary stasis, pH changes, and decreased protective substances. Calculi commonly form in the kidney, pass into the ureter, and are excreted in the urine. Because not all calculi pass spontaneously, they may require a surgical extraction or pulverization using extracorporeal shockwave lithotripsy. Calculi don't always cause symptoms, but when they do, hematuria is most common. If calculi obstruct the ureter, they may cause hematuria, severe flank pain, dysuria, and urinary retention, frequency, and urgency. To test for urinary calculi, the patient must have all his urine carefully strained to remove any calculi. Qualitative chemical analysis then reveals the calculi's composition, which helps to identify their causes. So the purpose of this examination, the goals of imaging of urinary calculi are to determine the presence of stones within the urinary tract, evaluate for complications, estimate the likelihood of stone passage, confirm stone passage, assess the stone burden, and evaluate disease activity. It is also done to identify substances present in renal calculi. So for the results, for normal results, calculi aren't present in the urine. For abnormal results, more than one-half of all calculi in urine are of mixed composition, containing 2 or more mineral salts. Calcium oxalate is the most common component. Determining the calculi's composition helps identify various metabolic disorders, guiding proper treatment and prevention measures. Let us now proceed to the nursing considerations. First is before the procedure or examination. First is explain that this test detects urinary calculi and that laboratory analysis will reveal their composition. Tell the patient that his or her urine will be collected and strained. Inform the patient that he or she does not need to restrict food and fluids. Inform the patient that the medication to control pain will be administered. Next is during the procedure. Confirm the patient's identity using 2 patient identifiers according to facility policy. Have the patient void into the strainer. Next is to inspect the strainer carefully because calculi may be minute looking like gravel or sand. If calculi are found, document the appearance of the calculi and the number if possible. Place the calculi in a properly labeled container and send the container to the laboratory immediately for prompt analysis. Next is to observe the patient throughout the test for severe flank pain, dysuria, and urinary retention, frequency, or urgency. Next is the hematuria. Hematuria should subside. So after the procedure or examination, inform the patient with kidney stones that the likelihood of recurrence is high. Educate the patient regarding risk factors that contribute to the likelihood of kidney stone formation, including family history, osteoporosis, urinary tract infections, gout, magnesium deficiency, Crohn's disease with prior resection, age, and gender. Males are 2 to 3 times more likely to develop stones than females, and climate. Next is nutritional therapy is indicated for individuals identified as being at high risk for developing kidney stones. Educate the patient that diets rich in protein, salt, and oxalates increase the risk of stone formation. Adequate fluid intake should be encouraged. Next is follow-up testing of urine may be requested, but usually not for 1 month after the stones have passed or been removed. Lastly is to evaluate test results in relation to patient symptoms and other tests performed. And lastly, for the precautions, keep the strainer and urinal or bedpan within the patient's reach. If he or she has received analgesics because he or she may be drowsy and unable to get out of bed to void. Next is tubular reabsorption of phosphate. The test for tubular reabsorption of phosphate is an indirect measure of parathyroid hormone or PTH levels. PTH helps maintain optimum blood levels of ionized calcium and controls renal excretion of calcium and phosphate. Specifically, PTH stimulates reabsorption of calcium and inhibits reabsorption of phosphate from the glomerular filtrate. Regulatory feedback mechanism results in diminished PTH secretion as ionized calcium levels return to normal. In primary hyperparathyroidism, excessive secretion of PTH disrupts this calcium phosphate balance. This test measures urine and serum phosphate and creatinine levels. These values are then used to calculate the tubular absorption of phosphate. The purpose of this examination is to evaluate parathyroid gland function to aid in the diagnosis of primary hyperparathyroidism and to aid in the differential diagnosis of hypercalcemia. For normal results, renal tubules normally reabsorb 80% or more of phosphate. For the abnormal results, reabsorption of less than 74% of phosphate strongly suggests primary hyperparathyroidism. Hypercalcemia is the most common sign of primary hyperparathyroidism, but a patient with hypercalcemia may need additional testing to confirm primary hyperparathyroidism as the cause. Let us now move on to the nursing considerations. So before the procedure or examination, you should explain that this test evaluates parathyroid gland function. Advise the patient that the test requires a blood sample and urine collection over a 24-hour period. Tell the patient who will perform the venipuncture and when. Next is to advise the client that he or she may experience slight discomfort from the needle puncture and the tourniquet. Instruct the patient to maintain a normal phosphate diet for 3 days before the test because low phosphate intake or less than 500 milligrams per day may elevate tubular reabsorption values, and a high phosphate diet of 3,000 milligrams per day may lower them. Common nutritional sources of phosphorus includes legumes, nuts, milk, egg yolks, meat, poultry, fish, cereals, and cheese. These foods should be eaten in moderate amounts. Next is to instruct the patient to fast after midnight the night before the test. Notify the laboratory and practitioner of medications the patient is taking that may affect the test results. They may need to be restricted. If they must be continued, note this on the laboratory request. Next is during the procedure or examination. First is to confirm the patient's identity using 2 patient identifiers according to facility policy. Next is to perform a venipuncture and collect the blood sample in a 10 ml clot activator tube. Next is to instruct the client to empty his or her bladder and discard the urine. Record this time as time 0. Collect the patient's urine over a 24-hour period with the first sample discarded and the last sample retained. Occasionally, a 4-hour collection or a random collection is ordered instead. So lastly is after the procedure. First is to allow the patient to eat and encourage fluid intake to maintain adequate urine flow after the venipuncture. Apply direct pressure to the venipuncture site until bleeding stops. Apply warm soaks if a hematoma develops at the venipuncture site. Tell the patient to resume his or her usual diet and medications stop before the test as ordered. And lastly, for the precautions of this procedure, keep the urine specimen container refrigerated or on ice during the collection period. Uremia, renal tubular disease, osteomalacia, myeloma, and sarcoidosis may cause a possible increase in reabsorption.